In this video titled Passive Unwind, a novel way of managing intraoperative fluid misdirection syndrome, we present a case of vasoemulsification in a 76-year-old man diagnosed with mature cataract in his right eye. First, a sideport incision was made and air was injected into the anterior chamber. This was followed by injection of trypan blue to stain the anterior capsule. We can see that the incision was small and it did not allow free outward flow of the fluid. After washing the anterior chamber of the excess trypan blue, viscoelastic was injected to maintain the anterior chamber space. A 2.8 mm size clear corneal incision was made. On attempting to inject the viscoelastic, iris prolapse with outward escape of fluid from behind the iris was observed. The self-retaining eye speculum was loosened to relieve the positive pressure, and on injecting the viscoelastic, there was outward escape of the viscoelastic without any apparent deepening of the anterior chamber. Another attempt to inject the viscoelastic is made to deepen the anterior chamber, but there was outward flow of fluid from behind the iris without any deepening of the anterior chamber. As in a normal case, capsular rhexis was started, but peripheral extension was noted due to the positive pressure with escape of fluid from behind the iris again and shallowing of the anterior chamber. To relieve this positive pressure and to deepen the anterior chamber, a 23 gauge sclerotomy port was placed 4 mm behind the limbus. This was followed by egress of the blue tinged fluid, which is suggestive of fluid in the retrolenticular space. This was followed by the deepening of anterior chamber. Viscoelastic was again injected and the capsule was cut with micro scissors near the point of extension. Rhexis was started with rhexis forceps. Viscoelastic is again injected and the rhexis is continued with cystitome. Viscoelastic is again injected and rhexis is completed. As we can see, maneuvering inside the anterior chamber became easy after passive decompression by the sclerotomy port. To regularize the capsular rhexis, the capsule was again cut at the point of extension and rhexis was enlarged with the rhexis forceps. After completion of the rhexis, nucleus was emulsified by the direct chop technique. At the end of the surgery, we observed that the reflex was blue instead of the normal red reflex. Post-operative best-corrected visual acuity was 6.6. Most common modes of management of this complication include needle aspiration technique, which has a risk of engaging the vitreous, and pars plana vitrectomy, which requires posterior segment visualization. Thank you.